So I was like, it's time to hang it up. Yeah. Please do. We love it. I mean, my kids, they all still love it. Bruce snowboards and skis and they love it. And I go along. It's not like I'm like, I won't go along. It's fun.
You're together, but you're all kind of doing your own thing.
Okay, so some of them are in the gallery.
Yes. So
All right, we're at 4:30. We've got 1, 2, 3, 4, 5 of us. So we have a quorum.
plans and wants, but it's not called that. Environmental.
Okay,
All right, folks, we're going to go ahead and get started.
great.
So I'm going to go ahead and call this meeting to order at 4:31, and we're going to take a roll call. But just before, is this working?
It's working. We're
Oh, nobody's listening. Okay. So before, that's all right. So before we take a roll call, we want to introduce our new board member, Ellen Higgins. Welcome. Rylander, thank
Yes.
you. Rylander, Ellen Rylander, welcome to the Board of Health. Welcome. We'll go ahead and take roll call. John Lynn.
Present.
Ellen Rylander,
Present.
Jason Marker,
present.
Michelle Migliori,
Present.
Jamie Shoemaker, and Ilana Kirsch. Ilana must not be here. So, and then of course we have present Dr. Mark Fox and Dr. Einters. Marcel Levin is here. Cassie White, Robin Vita. I'm seeing Jody Peretz, that's what I thought. And Ilana Kirsch is in the room. And there's Mark Espich and of course, Jenny Parcells. So we are all here. So moving on to number 2, adoption of the agenda. It's recommended that the Board of Health members adopt the agenda for the February 16th, 2022 meeting. Can I have a motion?
So moved.
A second?
Second.
No discussion, excuse me. We'll take a vote. All those in favor of adopting the agenda as presented, say aye.
Aye.
All those opposed? The ayes have it. We have adopted the agenda. Moving on to number 3, approval of the minutes. It's recommended the Board of Health members approve the minutes of January 19, 2022. Can I have a motion?
Excuse me, Heidi, point of information. Is
Yes.
this the agenda with the corrections in it? Like,
The minutes with the.
we can just go right to that.
Yes, exactly. Thank you. Yeah, because that was sent out ahead of time. Yes, thanks. Thanks, Jason. Motion for the approval of the minutes from January 19th.
So moved.
Second.
Thank you. Any discussion? Hearing no discussion, we'll vote. Approval for the minutes, please say aye.
Aye.
Any of those opposed? Ayes have it. We have approved the minutes. Board President announcements. I am just thrilled that we have a full Board of Health. So again, welcome, Ellen, to the Board of Health. Moving on to agenda item number 5, that's the health officer's presentation and report. And now I turn it over to Dr. Einters.
Thanks, Heidi. Is this on? Doesn't
Gotta
sound on.
bring it in pretty closely.
It's like real,
Oh, there
boy.
we go.
Yeah, I got to be real close. Going to eat this thing. There's really not much to report that's new. You should have in front of you the usual monthly review of each of the units. I do want to point out just a couple of things in the financial report. And it really is the first one, the county health department. I don't want to get your hopes up when we look at the revenue coming into the environmental and foods. You'll notice it's $221,335 in the month of January. And if that would continue for the next 11 months, I personally would retire immediately. But unfortunately, that was just due to the permits, right? Of month of January is renewal of the permits for in foods. And so we will not see such a number in the future. So didn't want you all to get confused by that. And that was
Can I
pretty
ask a
much.
question on that?
Yes, please. And Amy's on the phone and of course will be the expert when it comes to this. I'll do my best, but I'll probably defer to Amy. She has laryngitis though. So yeah.
Okay, can you hear me?
Yeah, I
Okay.
can hear you. I don't know if.
When I was looking at the minutes, I saw that probably Amy had written that maybe something like 75% of permits were renewed
Yeah, that
on
was.
time, and then people have a they have a fine if they don't renew on time. But if they continue to not renew, say, a restaurant, a food service permit, what happens to that establishment?
Well, that's actually a Carolyn Smith, and she's the one that had written that in the foods
Okay.
unit. And I see that she's on the line. So Carolyn, what do you do when they're so delinquent?
Okay, so in the month of February, we do reach out by phone and by visits. And if they are still delinquent, they get a 3-day letter. And the 3-day letter says you must renew within the next 3 days, or else we will close you and you will remain closed until renewal is completed.
Okay.
And to be clear, to be fair, it's not really a fine. We just charge more if they're delinquent.
Right. It's
So-
a late fee.
Yeah, it's a late fee. Yeah, it's a late fee, which is, takes a little bit more work to cover these delinquents. And so, yeah, thank you.
Actually, I have a question. And
Sure.
It's probably an I'm new here question, but I was looking through the budget and the section where it says health vector. They talk about a vector program to address Eastern equine encephalitis from a local philanthropic foundation which prefers to maintain anonymity.
Uh-huh.
And I was just, this is more of a general question. And maybe probably a legal question, like, is that allowed?
Yeah, it is.
And can you, okay, how is that? So a private foundation can donate money anonymously to the health department? Do you have to?
I think,
Any health governmental entity. So there's a
Okay.
statute in Indiana that says if you want to governmental entities anonymously, you can do that. And
Okay, is
they
there
can
like a
make,
cap on how much you can donate?
I do not believe so.
Okay, cool. Thank you for telling me.
and individuals can donate as well anonymously, right?
Were you thinking of donating?
I was suggesting, that we do. So,
I have a question, has to do with masking in the schools. And are you the one providing the guidance to Penn Harris Madison for the limit on the people that can participate in the snowball?
yeah, thank you.
Stop it.
Yeah, okay, fine.
Mark sent an email back on that.
Well, that's great, but I want to.
He did.
Yeah,
So why don't we pause that one? We'll finish up Dr. Einter's health officer report, and then let's switch over to the COVID
Because
conversation.
it's a terrific question and we do want to address it
Yeah,
in public because
absolutely.
there is a fair amount of misinformation that's out there regarding that. So.
Are there any other, let me just ask the board if there are other questions for Dr. Einters regarding the health officer's report.
I just have a quick kind of on the public health unit, the nursing.
Uh-huh.
At the bottom, there's an asterisk and it says bats. I was just curious. What's,
It says what?
it says bats. And I'll just-
What page is that, John?
It's right after, there's a mobile immunization clinic report, and then right after that is the nursing public health unit. It's kind of a chart. At the bottom, it just had an asterisk with bats, and I was just curious
Well,
how bats made it on there, and what if we have a,
as you know, we do have to follow up any bat exposures and bat bites. I'm trying to find,
I mean, it appears under the box called animal bites. So is that,
right, that's one of the
It's-
animal bites
it's
that
one
we
of
need
the
to follow
animals.
up on.
just a little asterisk at the bottom?
Oh, you know what? Actually, I didn't bring that down with me. Could I see it? Yeah, thanks. Yeah, this must have been from, this is just for January, and as best I can tell, and I don't think Nancy Pemberton is on the line, and she's the one that gave this to us. I'm not sure if, I'm not sure on this one. I'd have to check on that, John, because I am aware, and I reported last month, that we had a bat exposure and a bat bite that was rabid. And I don't know if that is the specimen that was sent to the ISDH lab in January or not, or maybe that occurred in December and that's why it's not showing up here. But bottom line is, I don't honestly know. And I'd have to look at some of the previous reports and to see when we did have bats, if there was something that was starred like last December's. I can look into that. I'm just not sure.
Thank you.
Actually, on the next page where it says vital records unit,
Yeah,
I'm curious about this. They say records filed in January 2022 and year-to-date 2022 occurrences. And for this year, the numbers are different in total deaths. Is there I guess maybe it's me trying to figure out how to read this, but so it's saying birth statistics, total births in January 2022, or is this?
Yes.
Yes, okay. And then total deaths in January 2022 were 319, but the year-to-date occurrence is 340. Is that just a typo?
That seems like an error.
Okay,
It seems like an error.
okay.
it may or may not be a typo. I would just have to ask, is
Okay, because
Erica on?
because it was like a,
It would be the same exact number of births and deaths.
yeah, well, and I would think the monthly
I bet
number of
this is wrong.
319 would be the year-to-date
Yeah,
number.
I bet one of these is wrong because I wouldn't expect them to be the same number.
Okay, maybe that's probably a typo.
Well, though I would also question, in terms of what the records actually filed as opposed to actual occurrences.
Yeah.
Okay,
And so,
It's
Oh,
filed from
there's
the
a
month
delay.
before.
yes, there's going to be a delay
okay.
in these things, and it does not happen immediately. And so that's what we would see.
okay,
And there's more of a delay with death than with birth.
For sure.
okay,
Yeah.
okay. So you aren't going to see them be automatically the same. Okay.
Any other questions from the board for Dr. Einters? Not hearing any, we will close that part of the agenda and then we'll move on to Dr. Fox to give us an update on COVID-19 and then to speak directly to Dr. Shoemaker's question about Penn High School. Go ahead, Dr. Fox.
So in the month of January, we still were largely dealing with the Omicron surge. The peak of that was from January 7th to January 21st in St. Joseph County, where our numbers really had plateaued with case rates up as high as 1,295 per 100,000 cases per week, which is higher than at any point in the pandemic. Hospitalization numbers peaked in I think the 180s, and had stayed kind of 150 to 180 for several months. Fortunately, we've come down precipitously, both on cases, dropping now to, I think, 140-ish cases per 100,000 per week as of today. Hospitalization numbers look much better in terms of both COVID patients hospitalized as well as total hospital capacity in St. Joseph County. The percent positivity is a little bit slower to recover, but we're down under 10% in the county as of today. And actually local labs are reporting, numbers around the 5% range. So all of that is very encouraging. That said, a lot of our effort in January was working with both higher ed institutions and K through 12 schools in responding to Omicron surge when there was decreased access to testing. There was kind of an inconsistent supply of rapid antigen testing in stores. And for a while, the State Department of Health did not have any rapid antigen tests to supply. We were able to work with HealthLink, the federally qualified health center, to make some tests available to area school districts. So, very grateful to HealthLink because their tests came from a different federal source. And so they had a different brand, but greater availability of tests that they were able to make available for area school districts. So fortunately, we're through the worst of that. Part of that guidance, though, Jamie, to your point, did revolve around snowball. So back even before the winter holidays, I encouraged them to postpone the snowball dance, which was originally scheduled for mid-January, and to put it off until sometime after February 1st, based on the projections for the Omicron surge. So they were able to do that, scheduled for this coming weekend. The Department of Health played no role in establishing a capacity limit for that event. The school leadership determined that based on the venue that they're using. And my understanding is based in part on historical attendance at the dance. So they set that limit at 1,000 people. Somehow there is a perception that the health department drove that. We did not. They did reach out to me this week and ask about increasing the capacity by either 100 or 200. And I think they were making some adjacent spaces available to be able to do that. We had no objection to that plan at all. We also have been working with the K through 12 schools on transitioning mask plans in anticipation of the governor's public health emergency order likely expiring and not being renewed in March, after March 4th. So most area districts, we're really targeting that date as a transition point for them, as it has implications for mask wearing and associated implications for how contact tracing is done, and et cetera. So it was a bit of a surprise when the PHM board chose to accelerate that plan and go mask optional as of tomorrow. Dr. Marker sent a very helpful email this afternoon that kind of summarized the current CDC recommendation in an effort to keep schools open and to reduce the need for quarantine and contact tracing, recommends universal masking in schools for students, faculty, and staff. That has been our position because by both the state and CDC metrics and our own metrics, despite the improvement in case rates and positivity in the county, we're still an area of high transmission. The other part of the CDC recommendation is in areas of substantial or high transmission, they recommend indoor masking in public spaces, irrespective of vaccination status. That's the current recommendation. There's some thought that the CDC will update their mask guidance in the near future, but that's their recommendation at this point. One thing I think the board should be aware of is that the State Department of Health uses the same metrics, but different cut points on their metrics for their red, orange, yellow, and blue zones. The CDC is, and we're more closely aligned with the CDC in that, but use a different cut point both for the case rate per 100,000 and on the percent positivity. So there is discrepancy there. The other problem is, our metrics and CDC metrics are updated daily, where the State Department of Health metrics are updated once a week they're updated on Wednesday based on data from the preceding Sunday. And so there can be a change. Even in the last 10 days, we've seen pretty significant change in our case rates and our percent positivity. The state metrics won't pick that up for, potentially 10 days, whereas the CDC and our metrics are more real-time reflections of those measures. So bottom line is we're headed in the right direction, which is great news, but we are still considered an area of high transmission in St. Joseph County.
Thank you for that. You need to know that the Department of Health is being implied in the communications from the principal from Penn Madison High School. And I think that it's deplorable that it's sold out for these students. There are students in this grade that can't attend because there's not enough space. And the latest communication I got from a citizen talks about their cooperation and collaboration with the St. Joseph County Department of Health and with plans during the pandemic. That's how they made their plans for this. And that's what's being sent to parents. So you should be aware of that. And so I think what should happen is if you think it's okay, which I think it is, you should let them know that they should open this up to any student that's able to go to the dance. This should not be sold out. This is at the Penn High School main arena. And
it's not in the
now-
main arena, or it was not originally planned for the main arena.
It's okay. It's now in the main arena and maybe that's for space, but any student should be able to go to this. I mean, they've had 2 years of hell from COVID where they had to wear masks, all these things were canceled. I think it'd be a great gesture for you to say, you know what, if you want to do this, the students should be able to go to this. I mean, they have a chance. Students can be vaccinated if they choose to do so. They're able to wear masks if they feel they want to do that. But to see, I just went on Eventbrite, it's sold out. I think that's inappropriate. And I think that the latest email from Gallagher to a parent says it's in conjunction with the Department of Health. So if it's not, I completely, I
Well,
trust you.
I meet with PHM leadership every week. At times, we've discussed snowball. We've had no role in establishing a capacity limit.
Are they
So-
using social distancing? Is it past guidance that you gave them? Maybe you need to step up and say, you know what, this is okay to have this dance.
I have provided guidance appropriate based on CDC recommendations. And I'm comfortable with the guidance I've provided. Their leadership has been very clear that they set the capacity limit, not me. Attendance at the dance is not a public health concern about, whether everyone in the school should be allowed to attend or not. So
You're on the Board of Health. Tell them yourself, Jamie.
Well, give me the information. I will.
You just got the information. You could have asked us earlier. We're tired of being pilloried by you.
Oh. well,
Just stop it.
I don't.
This was not us. You know that.
No, I
And
don't
yet
know
you're
that.
doing this as a board member. Stop it. And stop. And get off of Dr. Fox's back.
With all due respect, no, time out. No. Tap the
No
brakes.
timeout, nothing. You are causing a problem.
Oh,
Dr.
Okay.
Einters, that's not appropriate.
that's not appropriate.
Not
I am
appropriate.
as a.
Hold up,
let's-
I am the president of the Board of Health and I will call order. I'm not going to have this. Dr. Fox has answered the question
And then I got belittled by this gentleman
And-
here.
and
Unprofessional, unethical. I was brought to this board to represent the citizens of the county. I asked you a question.
No,
and
you are
answered it.
here. You are here
Yeah,
to
absolutely. I'm
promote
here, and I
health
got
in the
answer.
county.
Oh, I'm told not to send emails because it could be discoverable, all this different stuff. So we're phone call communications. So all of a sudden now I asked a
You're
question.
attacking Dr. Fox in a public meeting.
I'm asking him the question. If here is an email from the principal that says it came from the Department of Health.
And
And
he
he
told you
represents-
no.
Can I
And
push-
he didn't do it and you pressured and continued to push.
I told
I'd
him it was a
ask you to
plot.
stop it.
No, you told me I'm a problem on this board. If that's, you're gonna have a real issue. 'cause I'm
excuse
not going
me,
anywhere.
I'm going to have to push pause on this.
Mhm.
We can have a conversation afterwards and finish this up. The thing with the high schools, what I have noticed, and also with Notre Dame does the same thing, they seem to generally always include the Department of Health, don't they? They always say in conjunction with or in consultation with. And so I think sometimes that language gets dropped in just about I know at Notre Dame, I can speak for Notre Dame, I see that language in nearly every single communication. We are in consultation with the health department. Dr. Fox says that he was not part of the capacity issue. I trust that Dr. Fox has been doing this now for 2 years. I'm going to accept that. The conversation that's happening now, I want to continue that afterwards. I don't,
really- no,
we
I
don't-
know why we can't continue that now, to be honest, because I've done nothing incorrect. I've asked questions. You're telling me to reach out as a board. I don't know how to contact these individuals. I trust your answer, but I didn't know that. Because now, I have my son has friends that can't get tickets to Snowball. So I'm going to ask you that question because the email.
I'm not sure why we are involved in,
And
the
I
Board of
asked you-
Health is talking about the number of tickets being sold.
I don't know. And now I know he didn't do that, but that's not what's being applied by the school board. That's all,
Okay.
that's all I'm saying.
So to close out this part of the conversation, we hear from Dr. Fox. He is not part of a capacity discussion. I think that we need to end that part of it because, of course, we have nothing to say about capacity, right? They choose their venue. My children went to Penn. They made all those choices, but the Board of Health wouldn't weigh in on where you can have your function or not. So
Yeah, but to be personally attacked for asking tough questions or questions you don't want to answer isn't appropriate, and I won't stand for it. I was asked to be on this board, but to bring my expertise, I'm going to ask questions. It may not always be in lockstep with what you all think, but that's just how this works. And so that was
at no
inappropriate.
time would we expect people to be in lockstep with each other, because of course, that's not public discourse. But we do have to show each other professionalism. Obviously, things got heated, things have been said. If we can, please, let's maintain that level of decorum and
Oh, absolutely.
professionalism, and let's move on to the
I
next
have no
topic,
issue with
please.
Dr. Fox. Dr. Eintertz, that was unprofessional.
Said and noted.
Thank you.
It just sounds to me like there might be a problem with perhaps some educational institutions around here and saying, for example, it sounds like what you're saying is that they talked with you, they wanted to get what you had to say, but then it's Penn High School itself that is making this decision. Is there a way that maybe the Board of Health could, clarify that? It sounds like, and I'm just, from what I'm hearing, that Penn High School is trying to craft its language so that even though they're the ones making the decision, they're trying to imply that you were the one who was kind of pushing them in a certain direction when it sounds like that's not the case. Is there a way that the Board of Health can request that institutions like this say that we consulted with them, but the decision is entirely our own? Because it seems like everybody wants to pass the buck on these unpopular decisions. And if this was Penn High School's decision solely to make these capacity limits that apparently are causing, a lot of, kids to not be able to do something that they've been looking forward to for a long time, it seems like Penn High School needs to own it and not try to pass the buck to this board. Is there a way that we could request that clarification? And I'm not saying that it was anything that you said it in some sort of conversation, but I wonder if going forward, is there a way that we can kind of request clarification and not squishy lawyer language?
Yeah, very often, they will give me the opportunity to review district-wide communication about changes in policy. Not always, but, I'm a PHM parent as well. So, but they will occasionally run something by me, and how they reference either me individually or the Department of Health. I have not seen whatever communication Dr. Shoemaker's referring to, but the high school principal usually is not in the weekly leadership meeting that I have with Dr. Thacker and the COO and a few other members of his leadership team. So it may be something that is not, that a building principal is not necessarily aware of, and may be misrepresenting that, where the decision-making lies in communications to parents. But the COO has been very clear when parents have asked him that it was not the Department of Health that set the capacity limit.
If I could ask, we see a lot of states that are basically getting rid of masks in schools, and my particular issue is with schools. Can I ask that as you evaluate the data of our county, I'm not the CDC, I don't really know much about them, but they seem to give very broad, and their data sets are not always great, in my opinion. And we see other states that are getting rid of the masks across the board, even in schools. I just want to just mention that I don't think it's without cost to our children that they wear these masks. And as soon as you think we can get rid of them, regardless of the CDC, I trust your judgment, not some bureaucrats that have never seen a patient, in Washington, DC. I would ask that between you and Dr. Einterns, please do that and not wait around and just lean on the CDC, because I don't think they know what's going on in St. Joe County, Indiana. Thanks.
Thanks, John.
One quick follow-up question for you about the color method cut points. As we come down then from red into the other colors, is our county color chart likely to arrive at a place where we can have that conversation about school masking sooner or later than the state? I understand there's a difference between a couple of different cut points. Whose is where? I don't remember that from a few months ago.
So ours is more conservative, but more real time than the State Department of Health. The State Department of Health takes an average of case rate and percent positivity, and there are some challenges with that. This academic year, we didn't have any specific recommended actions tied to our color zones, whereas last academic year, we had specific recommendations of when to go virtual, when to do some hybrid, and when full in-person instruction is possible. So we've shifted away from that based on data about transmission in school and the impact of universal masking on transmission in schools. And as a pediatrician, I'm a med peds physician. So as a pediatrician, I recognize the value of being in school and wanting kids to be in school and wanting schools to be open and to be open safely. So we don't have recommended actions based on those colors, but it's more to kind of give the gestalt, if you will, of yeah, we're still seeing fairly significant community transmission, or we're seeing improvement in that.
We're falling through the high transmission range, but a lot of the CDC definitions are based on when you get to low transmission.
Right.
And so their low transmission will be somewhere about, so when we hit the yellow into green range, as far as how we might understand our relationship as a county to the CDC guidelines around masking in schools.
Yeah.
Okay.
And, the PHM district at the beginning of the school year had adopted a mask action plan tied to public health metrics, of when they were required, when they were optional, and when, they essentially recommended no masking once they got into a certain level. And so again, it was a departure this week for them to say, we're accelerating based on, compared to what either the governor's public health emergency order has, or what the administration was recommending in consultation with me. And then to go mask optional sooner than expected, but also to say irrespective of any public health metrics.
Do you happen to know if they changed their policy or if they just decided to move against their policy and make a decision about masking independent of the policy?
I don't know the answer to that question.
Out of curiosity, what percentage of the population of the county do you think has had COVID at this point? Not vaccination, but actually had the disease of the COVID disease?
So I don't have that number like off the top of my head right now. We have previously done some calculations trying based on the best estimates. And this was in the Delta wave, that probably 2.5 to 3.5 times the number of laboratory confirmed cases, that was the estimate for the county. The issue, at least I believe the issue is how many have had a natural infection recently enough to feel pretty assured of having good natural immunity. Obviously, with the recent Omicron surge, a lot of people, there certainly were a lot of breakthrough infections, also a lot of infections in people who are unvaccinated. So that number over the last month or 6 weeks is certainly significant.
Okay. Do you know what the total number of COVID cases that we've had in the county in the past since the pandemic started, what that total number is?
Cassie, help me out. Total number of COVID cases identified in the county since the beginning of the pandemic. I can tell you in just a couple minutes.
Let me say something while Dr. Fox looks for that.
Mhm.
That's been a question of great interest for us as clinicians, because we think in terms of when we might approach a point where there is herd immunity.
Mhm.
And that has to take into account people who've had an active infection in a recent time frame that we believe could give them some natural immunity, which is inconsistent across the variants from the original variant through Delta and into Omicron, in addition to people who have been vaccinated. So trying to put all those people together, especially when there are now over-the-counter home tests available, we'll never know really the answer to that. And so trying to get some sense from our statistician and epidemiology friends, what is the calculation that we can use based on known test positives? Because the time course is going to be variable, who had the infection when and what type of infection was it. But maybe more importantly for me, which version did they have and how recently did they have it, and did they even let anybody know about that? I have lots and lots of patients who've been infected at home. They've talked to me about it. They took a home test. I believe that they were infected. I don't know how long they'll have their natural immunity as far as applying to the herd immunity pool. And it's never going to be part of the statistics that our county looks at. So we will likely never really have an answer to the question, are we there yet? It'll take clinicians sort of working together in our community to say, yeah, we think we're there.
Okay.
I think we'll know more that we're there as we see cases drop off with the effects of herd immunity. I read recently a statistic that said that before the Omicron surge, something like 40% of the country had been infected with COVID. And because Omicron is so transmissible, that there was a feeling that after the end of Omicron, that up to 80% of the country will have been infected, including, obviously people who have been vaccinated who have way, on average, way more mild symptoms, or maybe no symptoms, but up to 80%.
So is our current precipitous drop a sign of an arrival near herd immunity,
Right.
only herd immunity to Omicron, or would other variants be sort of mitigated by that?
And I guess we'll find out if,
Eventually,
as
yes.
more
Or
variants
is
happen.
this just the end of
Yeah.
this
Right.
wave? And that's what makes it hard to make recommendations about masking is if we know that this is sort of the end of an epoch of it, that's great. If it's a temporary blip like last June and July, then we'll be
Right.
back at this again in another couple of months. when
When
we're hearing-
Psi variant happens.
Yeah,
or,
so as a
whatever.
clinician, as a father, we monitor and we watch and we try to
Right.
do shared decision making with our patients around what is the best step forward for you individually.
But at the same time, it seems like our entire population is getting some various types of exposure to different COVID variants. And isn't it kind of like with the flu or colds, like over a period of time, just repeated exposure to various variants gives you some level of immunity if a new variant comes around? Isn't that typical?
Well, in the sense that we still have lots of people who die every winter from influenza.
Yeah.
I mean, at what point does a pandemic become an epidemic? And that's an epidemiological question based on statistics. But I think most of us clinicians, and I'm happy to be corrected by the other clinicians at the table, believe that we're going to cross a line at some point where this moves from a pandemic to an epidemic. And then we just have to, when we do that, we are basically saying, we now believe that there's a set number of people who will contract and die from this every year that is acceptable to us in this country. And then we will decrease some of these mitigation efforts because we'll just say like, this is the new normal now. When is the right time for public health officials to make that leap and say, this is just what we have to accept now and mask wearing doesn't make any sense. That's a policy decision.
Probably when the numbers are comparable to people lost from influenza. I mean, there's an ongoing epidemic of pertussis year after year. That's ongoing. It's been forever. It's never going away because people don't get vaccinated enough to pertussis. That's the same thing. So at some point, we'll see that the numbers of people being hospitalized and dying of COVID are significantly less than what they are now, which is still a high number. There's still a lot of people.
But we don't wear masks for pertussis and we try to
Right,
convince our
because it's
patients to
not
get a
as
pertussis
net-
vaccine.
right.
We'll get to a point like that with COVID. The question is when do we do that? Is that in the
Right.
spring?
At
Is it
some-
in 2 more years? Like
It could
that's.
be some point in the future. Who knows? It
Well,
could be a few
It
years.
seems like we also have to take into account not just the number of cases, but also all of the mitigation that we've been doing over the past couple of years. At some point, it goes on too long and it has too many other consequences. And I think masking kids is a great example of this. You know, when people first started doing it, we thought it'd be a month or two, you can, and you didn't think of it as being a long-term thing. But now I should say, my kids aren't in school, I homeschool. And I did that before the pandemic, but I would not have, if I had my kids in school, I would not put them in school if they had to mask. Because I'm concerned about the other harms that children are faced with in terms of language ability and development, in terms of social and emotional learning, communication with each other. And it seems like generally across the board, I think people are, I know of a lot of people who are kind of hitting a point where this has gone on so long that those other concerns about what is happening to us, happening to kind of our societal interactions, it's worth the risk of COVID.
And that's fine if you want to say that it's worth the risk for you personally, for your family, but as a public health board, we have to
Yeah.
think about societal risks. And until the hospitals are not overflowing with COVID patients, which they still are, then I think we need to view this from a public health perspective. And while I think we all appreciate your own concerns, which have been expressed by various other members of society, And we've heard those concerns and we understand and respect them and we are concerned also. But ultimately, I think we need to be concerned about the sheer numbers of patients in the hospital. You know, I, as a surgeon, have had cases at hospitals canceled or delayed because there were no beds for an overnight stay for my patient. And that happened as recently as December because the hospitals were so overwhelmed with inpatients with COVID and couldn't handle, you know, a patient who didn't have an emergency surgery. Well, you might say it's not an emergency. If she has chronic pain and needs her surgery, it's an emergency to her, but it's not considered an emergency. So until we get to the point where we don't have, you know, overflowing numbers of patients in the hospital, I think that we still do have to continue mitigation strategies to decrease community transmission.
What are the hospital rates right now in terms of?
Well, that's what Dr. Fox was talking about. They're coming down now.
Okay.
So we're just waiting and seeing. And, you know, at some point, they'll come down to a point where the hospitals are not overwhelmed with COVID patients. And then, as Dr. Marker said, we'll get to the point where we can call this an epidemic and not a pandemic, and we can decrease our public health mitigation strategies.
Is it simply an overwhelming number of COVID patients? Is
Mhm.
that why?
Mhm.
Or is it because of issues with staffing? Is it because of?
No, it's really a lot of COVID patients. It's a lot. a lot of
I would
COVID
say it's a
patients.
lot of.
That
things.
shift.
Yeah,
It's a
they're-
lot. I mean, it's
That's
staffing
not-
also,
Yeah,
but. you know,
December was COVID. Now it's
Now
COVID
it's
cases.
coming down.
Yeah,
you know.
markedly. Now it's
definitely coming
staffing's a
down.
real issue in our,
Right.
in many communities.
Sure.
Well, and to your
What
point,
is staffing is?
Staffing.
Okay, sorry.
Yeah.
didn't hear.
to your point about the other non-specific COVID-related effects on children's growth and development. Totally believe that. A lot of what we're seeing in the hospital now are folks who are having complications of their chronic medical conditions that they were not able to seek help for
Okay.
during the height of the pandemic. Who are now circling back around with their heart attack, their stroke, their bad knee replacement, their whatever it is, because they weren't taking care of those things because of COVID. And now they're in the hospital, not with COVID, though there's plenty of incidental cases of COVID picked up on those inpatients, but because they didn't have the ability or willingness to take care of some of those things during the pandemic. And they're
So basically, we're dealing with the backlog.
yeah, which, you can, individually, we can decide whether we call that a COVID-related stroke or not a COVID-related stroke. But we in primary care certainly do see that as something like, gosh, we didn't see this person for 18 months, even though we called and had telehealth with them. And now they've had a big heart attack. Like, that's sort of COVID-related. And it's the same thing as children who may have language delay because of wearing masks. And these are unintended consequences of an attempt to not overwhelm the US healthcare system during COVID. And that's a lot of what we're seeing.
And our
right
local
now as
health
well.
care systems,
Yeah.
more specifically.
And to go back to the original question, I apologize that, I'm so buried in the weeds of weekly and daily numbers. About 70,000 confirmed cases of COVID in St. Joseph County since March of 2020.
I'm sorry, what is it?
70,000,
70,000. Okay.
70,000.
What's the
Yeah.
time frame on that again?
That's from March of 2020, so 2 years. Now,
That's maybe 20%. So there's clearly way more cases than that.
yeah, so that would be about a quarter of the county population with confirmed cases. We know there's a multiplier there because a lot of people don't ever appear in that system, even more now with the availability of at-home testing. But as Dr. Marker was saying, it's the duration of natural immunity, we believe, really is predicated on how recent that infection is. Since the beginning of this year, in the last 6 weeks, we've had, and this is a rough number, so don't pin me to this, but 12,000 cases in St. Joseph, confirmed cases in St. Joseph County since the beginning of 2022. So, we were hitting 3,000 a week there for several weeks in January. So 12,000, give or take a few thousand.
For closure, is it worthwhile? I thank you for letting us know that you were not part of the decision for the dance to not limit capacity. Is it possible to communicate to them that you're not recommending limit, that if it's a venue size, because the dance is this weekend? Because it's clear that Principal Galler and stuff feel that they're still using information from the past and they're inferring it clearly, because you said you didn't communicate that to them, is it worthwhile to send them a quick communication, maybe even via email, that right now there's no limits, COVID restrictions on limiting attendance if the venue could facilitate this?
Yeah, as I said, they reached out to me this week and said that they were increasing the capacity and wanted to make sure we didn't have any objections, and I indicated that.
I do have another question. I'm just curious, what's the average age of somebody who's been hospitalized for COVID, in the past month or so?
Well, it's hard to quote an average. There is a discrepancy. We're seeing an older cohort of individuals who are vaccinated, at least with the primary series, oftentimes vaccinated but not boosted, and then a younger cohort of people generally who have not been vaccinated at all. So it's almost like this. There's a bimodal distribution with about roughly a 10-year gap between those two. So, mid 60s versus mid 50s.
Mark, when you say that they were vaccinated, the older group is vaccinated, had they received both doses, or is it usually just a one dose?
No, most of those had gotten the primary series. Many had not necessarily been boosted.
Okay.
That the booster data is a little bit squishy. I mean, it's just harder to track that down a lot of times.
Cool. Thank you.
But there was such a strong effort in the initial rollout of the vaccine in nursing home residents, and then with the age tiers in Indiana, a lot of them
Mhm.
got the primary series. The booster outreach for some of those populations was not as robust as that initial rollout.
Right. Thanks,
So-
Mark.
Oh, I'm sorry.
Why don't you, one more question, and then why don't we move on to our next agenda item? Go ahead.
Oh, I was going to ask, well, it was a two-part question, but when so is somebody fully vaxxed when they have the two-part series, or are you fully vaxxed if you have a booster as well?
Oh, that's a great question. So, operationally at this point, I would advocate that we consider, the most robust protection being attached to people who have completed their primary series. So for Johnson & Johnson, that would be the 1 dose. For Pfizer or Moderna, it'd be the 2-dose series. That's the primary series. And then a booster of whatever flavor. That offers the most robust protection. The CDC definition, and Jason, I know you were looking at all this today. The CDC, I believe, still says, at least in K through 12 schools, they consider completing the primary series fully vaccinated. So the K through 12 guidance is still predicated on that.
So for the hospitals in our county and for the county health department, you consider somebody to be fully vaccinated if they'd had either 1 J&J or 2 of the other, okay, but no booster.
However, the booster is known to decrease the
Yeah,
hospitalization
I guess
rate
I'm
by
just,
like 10 times.
okay, I'm just trying to figure out for purposes of the stats, like when you see stats, you're referring to stats, when it
So-
says fully vaxxed, I just want to know,
Yeah,
what does
so
that mean?
that's a great question. And to be clear, in the county metrics, when we report the percent vaccinated, that is simply based on primary series.
Okay.
Because the ability to track the booster doses, it's been difficult for the hospitals to get us reliable data on which of their patients are boosted. They have
Okay.
pretty good data on who had the primary series, and the booster dose has been much squishier.
Okay.
But when we report data on our county metrics, it is completion of the primary series.
And when are you considered fully vaccinated? So for example,
2 weeks after the vaccine.
okay, so if you've gotten a COVID shot, you got J&J because that's just one shot, and a week later you get COVID, are you considered, for the purposes of the metrics, are you considered vaccinated or unvaccinated?
That would be considered a breakthrough infection. No, I'm sorry, that would not be considered a breakthrough infection. It's only considered a breakthrough infection if it occurs 2 weeks or more beyond the final dose of your primary series.
So you'd be considered unvaccinated.
No,
So-
not fully vaccinated, yes.
So all of that data of unvaccinated people and hospitalizations and everything, that includes both people who haven't gotten any vaccines and people who've gotten vaccinated but
Partially
haven't.
vaccinated, but not fully immunized. Yeah.
Okay, do you have data that breaks down the difference between like people who haven't gotten vaccinated versus people who have gotten a vaccine and are still in that window in terms of hospitalizations?
Not in terms of hospitalizations, no.
I can read you an interesting statistic though from 3 weeks ago, okay? This is national data. The US death rate for unvaccinated was 9.74 per 100,000 people, okay? For fully vaccinated but lacking a booster, 0.71 per 100,000, so about 25 times less. No, 15 times less. And for those with a booster on top of it, 0.1 per 100,000.
Okay.
So going from unvaccinated 9.74 per 100,000 to 0.1. So 99% effective in preventing death.
Okay, and I guess I'm just asking about that window, like, I'm thinking of it in terms of I'm unvaccinated. I get the first shot, but I'm still considered unvaccinated for
2 weeks
two weeks after the second shot.
after you've
So-
completed your series.
2
So that
weeks
would be
after you
what?
complete your primary series. So
So what's the time from first shot to 2 weeks after second shot is what, 6-7 weeks? now
So
or
it's
something?
5 or 6 weeks, depending whether it's Moderna or J&J or Moderna or Pfizer.
Right.
And then it would be, 2 weeks after the
Okay.
single J&J
So
shot.
there's like a month and a half period where I'd be considered unvaccinated even though I have the vaccine in my body.
Because that's how vaccines work. They don't work the second you put them in. You have to mount an immune response. It doesn't matter if it's COVID or any other.
Yeah,
vaccine.
I understand that, but I guess I'd like, it would be nice to know the statistical data that shows unvaccinated, vaccinated, but haven't gotten a full immune response in your body yet. Full immune response, booster, but haven't gotten a full immune response to the booster, boosted with full immune response.
That's
It
a
seems
lot.
like there
It
should
could
be.
not exist.
In
Pardon?
turn, are
It's
you
a
asking in
lot.
terms
It
of,
doesn't
of
exist?
cases or deaths?
Pardon?
Are you
Either.
asking- So
I think that would.
this is
Hey,
fairly.
could I interject just for a moment? I know that this is a really interesting conversation and so forth, but in light of time and the board's education level already of other board members, perhaps there could be an offline conversation where you meet with Dr. Fox and you can have some of those questions answered. I would like to move on to our next agenda item, if that is all right with the rest of the board. But thank you for all of these questions. These are all things, Ellen, actually, that we have been talking about for 2 years. So there lots and lots to unpack, and the nuances between all of that data is actually, what do I want to say? That it's kind of mind numbing, actually, because it's shape shifting, things change. Data, just like what Mark was saying about how there's real-time data, there's a lag in data, and so who's responding to which data? Crazy. So anyway, I encourage you to reach out to Mark Fox to have a meeting so that you can continue that conversation. So moving on to new business, it's now time for Paul Burrows to give us a unit spotlight on public health emergency and the work that he's doing with preparedness. Paul?
Can you hear me?
Yes, we can.
Does Jenny have the slides up?
He's getting there.
Okay. All right, good evening, everyone. My name is Paul Burrows. I'm the emergency coordinator, public health coordinator for St. Joe County Health Department. And next slide, Jen. I've been with the health department since 2006. Prior to working in the health department, I worked 30 years for Simplicity Pattern Company in Niles, Michigan, where I was worked my ways up through the ranks and ended up being superintendent of printing. Left there in 96 and went to work for the Sisters of Holy Cross as environmental manager, worked under Sister Agnes Ann Roberts there until I came here to the health department. When I originally hired in, I hired in as a lead risk assessor, lead inspector. I did hundreds, probably thousands of inspections and clearance exams during a 5-year period. We also at that time had a program, lead safe work practice program that myself and another person who's not currently here with the health department, where we trained the contractors and led safe work practices and helped them get some of their supervisors certified in those roles for their companies. I assumed the role of public health coordinator in 2011. Next slide, Jen. The emergency preparedness coordinator role. This is a list of some of the things that I do. I act as a liaison with EMA and District 2 Healthcare Coalition. Our health department is a part of District 2 Healthcare Coalition and the local health department District 2 group. And the 7 counties are Elkhart, Fulton, Kosciuszko, Marshall, Pulaski, St. Joe County, and Stark counties. And we meet, well, up until COVID, we would meet monthly in Plymouth. The coalition would meet on a Wednesday and the health departments would meet on a Friday down there. And we're looking for that to resume a little bit starting next month on the health department side. They're still not sure on the coalitions, the healthcare coalition side, if they're going to go face to face yet. They've been doing everything virtual on Zoom. So I assist and organize health department response to emergency events, which means the last couple of years I've been pretty busy and working with everyone here who had to respond to the event, which almost was everybody in the beginning stages. It was, we didn't use everybody in the health department, but as things grew and as this event expanded, we had more and more to do. So we had to pull in more of our folks, get them trained into doing different titles, different jobs in different areas. When we got to a point where we had vaccine, we had to set up pods. One of the things that I do is for new employees, we do train them. We have an orientation, then we train them in incident command. We want them to have a basic understanding of incident command. So we have 4 required trainings for them. These are Fema trainings to give them an overview. So when we actually we went into live with it, we've always done just practices and exercises in the past, but with COVID, we actually had to use all of this information. We were fortunate in the sense that to set the Hedwig site up as a pod, that we had people that were familiar with pod operation. There's been a lot of turnover over the years in different departments in the health department. Dr. Einters came in at, I think he was only here a week or 2, maybe, when COVID hit. And so, everything, the whole health department routine, everything was really new to him. But so this ongoing training is important. So everybody is at the same, is on the same page when we start talking about things. We facilitate the ESF8 group. ESF8, or Emergency Support Function 8, is a group of healthcare and businesses in our county that we meet quarterly. And there are partners and some of them are stakeholders in some of the things that we do as far as emergency preparedness. If we need help from them, if we need resources from them, these are folks that we know we can go to for those resources or for that help. A guide to community partners and the importance of COOP plans, a continuity of operation plans. Currently, we're trying to get the long-term care facilities, the LTCs. A lot of them we found out during COVID did not have any plan B, let's say, or COOP plan, and therefore didn't have any resources and counted on the health department for resources early on. And so we've been working with them the last couple of months, trying to get them to establish a burn rate for the PPE they use in their facilities and to get them to have their own cache of supplies. I personally, I just don't trust that the Strategic National Stockpile is going to have those things for us when needed. It didn't work in the beginning stages. What we thought and what we trained for all these years, that we would have these supplies, didn't happen. And if it wasn't for the donations of PPE from businesses, from the local universities, from Notre Dame, and other people who had labs who had some of these items. Quite frankly, it would have been very difficult for these long-term care facilities because it was a matter of months before we started getting things trickling in from the state, supposedly from the Strategic National Stockpile. And we all know the story about N95 masks, which all these things were very hard to get. But with these partners, and again, a lot of them are part of our ESF8 group, and these massive donations we got from them, we were able to do our part, and IDOH was asking us to make sure we take care of the long-term care facilities concerning PPE. We have a lot of plans. I update these plans. We have MOUs with a lot of folks. We have MOUs with a lot of our ESF8 group. And then we have the MOUs with our pod, point of dispensing sites, of which there are 6 located around the county. I also help maintain and make sure our ERB, our emergency response vehicle, is running to the best of its ability. We've got one that we've had for a few years that we have a lot of trouble with. We've got a new one coming that should be here next month. And that's going to be a big help for nursing and for the mobile clinics, for the mobile shot clinics. I schedule trainings based on core capabilities mandated by the IDOH. If you can go to the next slide, Jen. These are capabilities defined by the CDC. We always know there's public health threats present. And, whether natural occurring or intentional terrorist activities, being prepared is what we want to be. And so you can see this list of 15 capabilities here defined by the CDC. And what District 2 does when we meet monthly, and what IDOH does, is we base our trainings that we have for the district, or we try to base our trainings that we can have for the county based off of these capabilities. And a lot of times they're tied to grants that we have, emergency preparedness grants, PEP grants that we have. These will be tied into some of the deliverables. They'll want us to, they may go say, take 1, 2, and 3, and we want you to address those 3 areas as part of the grant requirement. Next slide, Jen. As I said previously, all employees are required to complete the 4 FEMA ICS Incident Command System trainings. We give them 90 days to complete the courses. Once the course is completed, there's a short test at the end of it. And you pass the test, and then there's a certificate they print out, and those certificates go to Jen. She keeps them in their files. And the other thing this does, completing these 4 trainings, there's other trainings that FEMA, that come into our district, to our county, that FEMA will host, or that TEACS, another company out of Texas, will host, or that the MRC, the Medical Reserve Corps, could host. And a lot of them require these 4 trainings as prerequisites. So there could be a training coming into the area and you want to go to it. And what they're going to ask for is copies of your certificates to show that you've done these trainings. So that's one of the reasons that we have the new employees take these trainings, so they'll be able to take further trainings down the road if need to be. Next slide, Jen. Some of the plans that we have, that we're always updating, or always working with the state, or we're working with District 2 with these plans. We have our countermeasure dispensing guide, a pan flu plan, max prophy plan, our CERC crisis emergency risk communication plan. The new one, the EOP, emergency operation plan, is kind of a combination of all those previous plans I mentioned. And we're in the process right now of developing the EOP out, and also a TEP, a training and exercise plan. So we have a lot of plans. When COVID hit, all these plans, even though we have an emerging infectious disease plan, bits and pieces out of all these plans as far as organizing response is what we use. There wasn't one plan, like the pan flu plan didn't cover everything that we did during COVID, or the mass prophylaxis plan didn't cover everything we did. Setting up the point of dispensing site, which was St. Hedwig, and now is the lobby here in the County City Building. Next slide, Jen. These are the sites that we have MOUs with. They're strategically located around the county. If we go to the next slide, there's a map that's gives you a little more. We try to keep them located strategically so all population would have access to them. So you can see there we have LaSalle Intermediate Academy, Clay High School, Penn High School, South Bend Central Fire, Grissom, and down there in the lower left-hand corner of our county, John Glenn High School. South Bend Central Fire can also be used as a drive-through point of dispensing site. So that's kind of a plus there. It's used two ways. Next slide, Jen. We also have a group of businesses and organizations that are closed pods. Open pods are open to the public. Closed pods are agreements that we have with these organizations. We look at them as a win-win for an organization. What it does, it allows them, and when we're talking about these, I'm talking about meds now, I'm not talking about vaccines so much. If there was an anthrax release where we'd have to distribute Cipro or Doxy, these things would be pushed out to our closed pod partners, and they could distribute these things to their employees, and allows their employees to come into work, and so they can keep their business running. And it helps us because if we have to push out Doxy and Cipro to everybody in the county, over 270,000 people, that would be a monumental task. So it helps relieve some of that pressure off of us. Next slide, Jen. Did you miss one? ESF 8, I touched on that a second ago. All events start and end locally. So even though this is a pandemic, what we do starts with us and ends with us. And our ESF 8 partners are a big part of everything that we do. And so this kind of gives you an idea of who they were. I mentioned earlier, universities, medical, hospitals, mental health services. We work with the coroner's office. We have they have a mass fatality plan. EMA doesn't have resources, but they have the ability to get us resources. And it was kind of interesting during the COVID response, as far as the PPE side, when we were involved in that. EMA was getting PPE, but theirs was coming through Homeland Security side. And so we kind of worked with them. They had some things we needed. We had some things they needed, because they supplied fire departments, a lot of the EMS teams in the county. So we kind of worked together and was able to trade off and share some of the PPE that we had that they needed, and they did the same for us. Next slide, Jen. Moving forward, I'm retiring at the end of March next year. And so we have someone working with, Harry Gilbride's kind of picking up some of this stuff and learning some of these things. And he's doing a very good job. He's excited about it. And he catches on quick. He's a good learner. But some of the things that we want to do is to still procure PPE for future emergencies for us. And so we're working on, how big of a cache do we need? One of the issues we face when we talk cache for health department is storage. There is no storage space down here at the County City Building, and not just for us, but for anybody who works out of the County City Building. We have our emergency response vehicles stored at the county garage on Riverside out there by the wastewater facility. And we have, I know that I believe environmental, I believe Mark's got some stuff stored out there, or Brett's got some stuff stored out there. And we kind of have things spread all over. I've got a room on 9th floor full of PPE. I've got a room on 4th floor here at the County City Building full of PPE. I've got stuff in the basement. And we've got some things out at the Beacon Hub south of town. And what we want to do in the next couple of weeks is figure out what level of these things do we really need. The other thing we're doing is putting together the training and exercise plan for all the way through, actually through 2025. And that'll about, we'll go in and visit some things, some trainings that we'll have for our folks here in the health department, things like psychological first aid and other trainings, FEMA trainings, and probably some TEACS training. We'd like to have a lot of trainings. The problem is, even with COVID, some of these places aren't opening these things up anymore. So when things start, hopefully things are turning the tide and we're heading in the right direction. And like FEMA and TEACS and ACADA, some of these other places will make more trainings available as I guess the country opens up a little bit more. We also facilitate the Medical Reserve Corps, which is a group of volunteers. As you know, I think we had, and I may be wrong, but I know we had over 900 volunteers that we used, or that were on a list for Hedwick. I guess we had a response from over 900 people to volunteer at Hedwick. Probably very few of those were part of the Medical Reserve Corps. We have, at the time when COVID hit, we had 106 names in the Medical Reserve Corps. These are people who sign up. I'd go out in the community and do presentations at various community groups to try to get volunteers, or different health clinics or surgery centers to try to get some of the nurses to volunteer, sign up for the Medical Reserve Corps. The thing is that I believe that list needs to be scrubbed. One of the things that we met with Harry and talked with Robin about was possibly getting and Sarah, and I believe Cassie was involved in that, was getting that group of volunteers that we use for Hedwick, being able to get these folks, reach out to them and see if they'd be interested in signing up for the Medical Reserve Corps. The Medical Reserve Corps is a group that generally gets called up locally. Again, it's a volunteer. They could get called up statewide. They could get called up nationally. And when you sign up and volunteer with the Medical Reserve Corps, you have the option in there to sign up for those if you're willing to be sent around to the state at different locations. They did that during like the Henryville tornado. I had some people some nursing staff that went to Gary, Indiana a couple of years ago when they were doing a lot of lead testing, and they needed some help over there, outside help, to get all the lead testing done on children that need to be done. We had four off of the Medical Reserve Corps volunteer list that went over there for 2 days and helped do some testing there. We want to continue working with the long-term care facilities, in-home health, hospice, and other community businesses. We really want people to see how important the continuity of operation plan, or Plan B, is. Basically, with a letdown for the Strategic National Stockpile, we don't want to see people have to face that again. And we want to do our best to help them establish, give them the information needed to establish those PPE levels, and to help them know what to do if there's some kind of event that would really have a big impact on businesses or business in our county. Website update, we're doing that all the time. We think we're going to put some more resources on there for the public and businesses. It would be easier for us. A lot of times I know I've had inquiries from some of the businesses that we deal with that, I'm constantly sending them links or sending them plans, where if we have this stuff on our website, we can direct them right to the website and they can get that information there. So there's a lot of stuff in the works. I think you're going to see emergency preparedness reimagined. Just the fact that we were part of District 2, which I always thought was a good thing, but we found out with COVID that there wasn't anything that anybody could do to help each other. And we don't want to be in that situation again. So with that, I'm willing to answer any questions if anybody has any questions.
Thanks, Paul, for a very detailed presentation. We really appreciate it. And I know you played a really important role during the COVID response, especially during those early days when we were all scrambling to try and find our PPE. Do board members have any questions for Paul?
Mr. Burrows, this is Dr. Marker. Thank you very much for that report. I appreciate hearing those items. Here's my question for you. If money were no object, and of course we know that it is, but if money were no object, what are the one or two things that would be on your wish list to help our community be really even more prepared from an emergency preparedness standpoint in our community?
I'd like to see a system like reverse 911. And if you're familiar with reverse 911, that's actually a system where you can send messages out to everybody's cell phone. And, you know, communication is always a big breakdown when in anything. Anytime there's an event, communication always seems to be the problem. We had, and things changed so rapidly during, you know, this time in the last couple of years. And when I mean rapidly, it's like, okay, where are the testing sites? What are the hours of the testing sites? And we fielded thousands of phone calls here at the health department that were pushed around all over to everybody, and people, you know, people wanting information. And if we have a way to push that information to them, that would be one big help. The second thing, so some kind of a system, reverse 911, are there other systems out there that are similar to that help reach the masses? The other thing that I think would be nice would be to have storage, you know, one storage building someplace where we could, you know, once we establish what our PPE, what we think should be a safe level of PPE, because we don't know what the next big event's going to be, but we know there'll be one. We want to make sure we can address it, you know, with a little peace of mind, knowing that we do have the resources available to be able to do that. So storage and a mass notification system, I think would be extremely helpful.
Thank you.
Any other question? Thank you so much, Paul. We appreciate your time and effort on this.
Thank you. Thank you for giving me the time.
Absolutely. Hey, before I move on to the next agenda item, I need to remind folks that if you wanted to do public comment and you're on Zoom, just please put your name and city in the chat, and then we'll call on you in the order in which you've signed up in the chat. And then if you're here in the gallery, there's a clipboard by the front door there, and you can sign up, and then we'll call you in the order in which you're signed up. So moving on, we've got agenda item number 8, that's old business, and we don't have anything for that. So moving on to board notifications. We've had a few hirings. I think we've heard about most of these folks. LaRonda Jose is a community health worker with us now, and Jody, who's here in the gallery, is our new director of nursing, and Clara Davis, who has also been hired as a community health worker. And so we welcome our new employees. So moving on to public comment, this is a section of our agenda where we allow the public to have 3 minutes. At regular meetings, the public is invited to address the board for 3 minutes regarding items that are posted or not posted on the agenda. Individuals may only speak once during this section of the agenda. Speakers shall properly identify themselves by stating their name and address for the record. Personnel issues are not to be addressed during open sessions of the Board of Health, and the board president may interrupt, warn, or terminate a person's statement if the statement becomes personally directed, abusive, obscene, or inflammatory. So I'm going to go ahead and get started with public comment here in the gallery. And Andy Bruton, did I say that correctly? You may come up to the microphone. And by the way, for all folks who are doing public comment, I just timed the 3 minutes on my cell phone, and then I will let you know when those 3 minutes expire. You have the floor, Mr. Bruton. Go ahead.
Great, thank you. Hello, Board of Health members, my name is Andy Rutten. I own property at 55304 Cedar Trail. I'm a temper tantruming parent at Penn Harris Madison School District. I wanted to share some of my notes from speaking at Penn's awesome school board meeting on Monday night. My teenage son helped organize the mask-free event Friday, a student-led initiative. This event caught me by surprise. I didn't think any mask optional initiatives would pop up until spring. Why is there a hesitancy to wear a mask? They hinder socializing and education. They're dirty, uncomfortable, a nuisance that doesn't work well. These are reasons why I don't wear a mask unless working on a construction project. Some other reasons is, well, flu season is winding down, and of course, the inspiration of the fantastic Canadian trucker protest. This all comes down to mask depression, a mental health issue. Symptoms of mask depression include irritability, increased lethargy, and stunted communication. Other symptoms include increased apathy to school, teachers, authority, even parents. Symptoms may be temporary or permanent. Shaming those with mask depression seems like harassment. Alternate mandates such as partitioning and segregation may cause similar depression. And of course, contact tracing tends to punish those who aren't even sick and couldn't spread germs. So the parents had suggested next steps. COVID mandates, regardless of individual risk, seem arbitrary and capricious. They disrespect parents like myself who guide their kids on fundamentals of healthy living essential to being disease resistant and avoiding unhealthy dependency on medical intervention. Shaming those, other tantruming parents noted how PHM currently has minimal COVID cases and can use more localized, relevant metrics for decision-making. I'm disappointed in the St. Joe County Department of Health. I asked this board, is this the professional ethics of the Department of Health to insult public citizenry who do not wish to embrace their flawed data, unscientific recommendations, and arbitrary timelines?
You have 8 seconds.
Well, I'm done, so I was just seeing if I could get an answer to my question. Thanks for listening to me.
Thank you. Jenny, could you read off who is next on the Zoom for public comment, please? Cynthia Heckman Davis, you have 3 minutes. Please go ahead.
Thank you. I would like to thank our Board of Health, Dr. Fox and Dr. Eintertz, for the very, very hard job that they've had during this COVID pandemic. I'd like to thank during this meeting, Dr. Marker and Dr. Kirsch for the comments that you've made. The mitigation efforts of washing our hands, masking up, socially distancing have worked, and research shows that it has saved lives. I personally plan to continue masking up in public. I will certainly continue washing my hands, but I wanted to thank the Board of Health for all their hard work during this pandemic. And I wanted to thank Paul Burrows for an excellent report tonight. I think we'll all be better prepared next time. Thank you.
Thank you, Ms. Heckman. Jenny, who do we have next? Rebecca Go. You have 3 minutes. Please go ahead.
Hi, yes, my name is Rebecca Go, and I'm from South Bend, Indiana. I'm sorry, I had to pick up my kids, so they're in the back seat. I wanted to say, I wanted to thank the Board of Public Health and also the staff and the direction, the leadership of Dr. Fox and Dr. Bob of the Health Department in keeping our community safe in the last couple of years. I know it's not been done without criticism and without stress, both individually and collectively. And I want to commend you for your ongoing work and your fortitude in difficult times. I've been disappointed in listening in this meeting, how many times I've heard people use kids almost as a way to say, give me what I want, as though asking kids to mask is just the worst thing in the world. I have two kids. I have a 13-year-old and an 11-year-old. Both of them attend schools and both of them wear masks every day. And guess what? They're not suffering. They're not dying. They're perfectly fine. And I think that they'll be well adjusted. What they are learning about is care for each other, care for the neighbor, and care for the community. They're learning that their individual actions have collective responsibilities. In my day job, I'm the director of an office at St. Mary's called the Office for the Common Good. In this office, we promote the idea that nobody gets to have what is good unless everybody gets to have what is good. It's actually a really Catholic idea because I work at a Catholic women's college. And I'd like to hope that people who say that, well, my teenager can't go to this dance or my kids, I would never do that to them, would think about maybe teaching their kids different values, maybe teaching their kids the values of being responsible and actually like caring about their community. I would also say, finally, just that I think that it is kind of absurd to ask Dr. Fox to continue to state what he's already stated, when you could simply ask the principal of Penn Harris Madison to send out a revised statement saying these were our own internal policies and not throw the health department under the bus, because they've been thrown under the bus so often recently. I don't think that's a hard thing to do. I think it would be a very reasonable request. As an administrator, I know I respond to these kinds of requests all the time. Take some ownership, but please stop beating up our public officials. I just don't think it's right. Thank you.
Thank you, Ms. Go. Jenny, do we have anyone else? Okay, thank you. So that concludes the part of our agenda item number 10 for public comment. Our next meeting is on March 16th, 4:30, right here in this room, and we're adjourned. Thank you, everybody.
Thank you.